Toxidrome, actually generalized approach to a patients with acute poisoning. Although we have already discussed on OP poisonings and corrosive poisonings, it should be the first talks usually. So let's start. So to introduce, actually there is lack of Indian data on acute poisoning, but here is one study of 2010, Jesslyn et al., that assessment of prevalence and mortality incidences due to poisoning in a South Indian Territory Care Teaching Hospital. Hospitals, and they collected data from 2005 to 2008. They accumulated total of 1045 cases, and they showed that the 22.1% was from household, but the maximum was from pesticide, means 39.5%. So this is 39.5% pesticides, and among them 75% was organophosphorus. 26.1% was from medicine, some drug overdose. 22.1% from households. 12.1% from environmental, and among them 80% was from snake bite, and 0.2% was from heavy metals. So what is Toxidrome? So it is collection of symptoms associated with certain classes of poison. It's also called toxic syndrome. So sometimes it may be the only clues to the diagnosis, and diagnosis is complicated by possibility of the multiple drug injections, and it should be always ruled out from the other primary clinical causes that mimics Toxidrome, and probably it is a diagnosis of exclusion. So how you will approach, means generalized approach to a patient with some toxin overdose. So it is called a two-prong approach. One part is diagnosis, another part is treatment. In diagnosis, it includes history, physical examination, Toxidrome recognition, diagnostic test, and in treatment, it starts with ABC, that is airway breathing circulation, decontamination, another is don't mnemonics, that is means dextrose, oxygen, naloxone, thiamine, and enhanced elimination, focused therapy, and get some toxicological expert help. Now in history part, actually the history is often incomplete, it is unreliable and often unobtainable. Sources are from patients, friends, family, EMS, empty container, locations of incident, history of previous medications, liver renal disease, concurrent medications, previous overdose, history of substance abuse, and other medical legal reportings may also help. And for examinations, we should start with vital signs, physical examinations. In eyes, pupillary size is important, neurological status of the patient, skin, odor, and then Toxidrome. So how Toxidrome helps? If we go with one by one symptom, sign, all those things, then we can see if we take bradycardia, then the reasons may be propranolol, beta blocker, opiates, anticholinesterase drugs, antiarrhythmics, clonidine, calcium channel blockers, ethanol or other alcohols, digoxins, digitalids. It may be remembered by the mnemonic paste. Tachycardia may be caused by free base or other forms of cocaine freon, anticholinergic, antihistaminic, antipsychotic, amphetamine, alcohol withdrawal, sympathomimetic like cocaine, caffeine, amphetamine, solvent abuse, strychnine. T stands for theophylline, tricyclic antidepressants, thyroid hormones. Now if we consider hypothermia and hyperthermia, if patients comes with hypothermia, it can be remembered as Cool's mnemonics, that is carbon monoxide, opioids, oral hypoglycemic, insulin, liquor like alcohols, sedative hypnotics. In hyperthermia, the causes may be neuroleptic malignant syndrome, nicotine, antihistamines, alcohol withdrawal, salicylates, sympathomimetics, serotonin syndrome, anticholinergics, antidepressants, antipsychotics. If we consider the meiosis mydriasis, in meiosis the cause may be cholinergics, clonidine carbamates, opiates, organophosphates, phenothiazines, that is antipsychotics, pontine hemorrhage, sedative hypnotics, mydriatics, the causes may be sympathomimetics, anticholinergics, and withdrawal, means alcohol withdrawals maybe. So in investigations, it starts with routine test, that is electrolytes, renal functions, routine blood sugar, ABG to check the anion gap, serum osmolality and osmolar gap for all unexplained metabolic acidosis, pregnancy test for female of childbearing age, toxicology screening, and urine testing. Now, toxic vital signs. So if we consider the elevated anion gap, so the reasons may be methanol, metformin, ethylene glycol, toluene, alcoholic ketoacidosis, lactic acidosis, acetaminophen large overdose, cyanide, carbon monoxide, isoniazid, iron, ibuprofen, diabetic ketoacidosis, generalized seizure producing toxins, acetyl salicylic acids or other salicylates, paraldehyde, fenformin. So these are the causes of increased anion gap. And low anion gap also may be present. So the reasons may be increased unmeasured cations. The reasons are hypercalcemia, hypermagnesemia, lithium intoxication, elevated IgG in multiple myeloma, that is decreased unmeasured anions, hypoalbuminemia, and drugs like bromide, iodide, lithium, polymyxin B. And in investigations, we further check for normal serum osmolality. If we consider it is 285 to 295 milliosmol per kg, and the osmolar gap we check by the calculated, means the one is by measures and minus the original anion gap. So we measures by this equation, that is 2 into sodium plus glucose by 18 by 1 by 2.8. So measures, this is wrongly actually written here, measured serum osmolality equals to that I have told, and increase in osmolar gap indicates the presence of a low molecular weight osmolarically active substance in the serum. And toxic, এটা calculated ওটা. So toxic vital signs, so like increased osmolar gap, if we get, the reasons may be methanol, ethynyl glycol, diuretics like mannitol, DKA, isopropyl alcohol, and ethanol. Now oxygen saturation gap, another important thing, that is an oxygen saturation gap is if presents when there is more than 5% difference between the saturation calculated from an ABG and the saturation measured by co-oximetry. And from ABG machines, we check for the PO2 and oxygen dissociation curve. In co-oximetry, they check 4 different wavelengths directly measured values of HbO, HbH, HbCO, and methemoglobin. So the reasons may be, means increased oxygen saturation gap, that is methemoglobinemia, carboxyhemoglobinemia, that is carbon monoxide poisoning, cyanide, and sulf-methemoglobinemia. In investigations, there is abdominal films, like radio-opaque pills, drug-filled packets or toxic materials may be seen via radiograph, means X-ray, and chest X-ray that may show chemical or aspiration pneumonitis, cardiogenic or non-cardiogenic pulmonary edema that may occurs from acute lung injury and atelectasis. And potentially visible toxins that can be seen in radiography, that is chloral hydrate, cocaine packets, calcium, opium packets, iron, other heavy metals such as lead, arsenic, mercury, neuroleptic agents, sustained release or enteric coated agents. Now toxicological screening, it may be rarely needed, especially consistent clinical findings if there is, and non-intentional ingestions and asymptomatic patients. It helps. And there may be high false positive and negative, and rarely actually changes the management. And now if we consider the groups of toxins, so we can divide In this way also, there may be anticholinergic agents. Anticholinergic agents like antihistaminic, atropine, baclofen, TCA, phenothiazines, scopolamine, and the features caused by them are fever, mydriasis, blood vision, dry skin, ileus, urinary retention, flushing, tachycardia, psychosis, seizure, coma, and the treatment here is drug of choice is physostigmine. Now, cholinergic drugs that can be organophosphorus poisoning, carbamates, and the features may be due to muscarinic and nicotinic receptor, and due to means through the muscarinic receptors, the features will be, we can memorize it with the dumbbells, that is diarrhea, diaphoresis, urination, meiosis, bradycardia, bronchoria, emesis, lacrimation, lethargic, salivation, and nicotinics, it's actually occurs later, it's days of weeks. It is meiosis, tremor, weakness, tachycardia, fasciculation, seizure, somnolent, and the treatments are atropine and pralidoxime or other obidoxins and other drugs. Sympathomimetics agents, those are cocaine, phencyclidine, amphetamine, ephedrine, pseudoephedrine. So the clinical features over here are mydriasis, tachycardia, hypertension, hyperthermia, seizures, and the treatments of choice is benzodiazepine and other symptomatic treatment. Beta adrenergics drugs are beta adrenergic agonists, those are salbutamol, caffeine, tarbutalin, theophylline. Features may be tremor, tachycardia, hypotension. Treatment is beta blockade or potassium supplement. Serotonergic toxidrome, so drugs are fluoxetine, meperidine, paroxetine, sertraline, trazodone, clomipramine. Symptoms are irritability, hyperreflexia, flushing, diarrhea, diaphoresis, fever, trismus, tremor, myoclonus. Treatments are benzodiazepines and serotonin antagonist. Opioids, the drugs are heroin, morphine, fentanyl, oxycodone, hydrocodone, codeine, methadone. Features are meiosis, bradycardia, hypotension, hyperventilation, coma. Treatment is naloxone. Hallucinergic drugs, those are or toxins, those are amphetamine, cannabinoids, cocaine, lysergic acid, diethylamide, and features are hallucinations, psychosis, panic, fever, mydriasis, hyperthermia, synesthesia, means hallucinations, and treatment is by benzodiazepine. Sedative hypnotics, the drugs are anticonvulsants, barbiturates, benzodiazepines, ethanol, opiates. Features include stupor, coma, confusion, slurred speech, apnea. Treatment flumazenils, naloxone, urinary alkalizations for phenobarbital. Now this is a flow chart. Actually we can approach a patient with poisons. So there is three important things. One is pupillary size, that is whether it is a meiosis or mydriasis or normal sized people, bowel sounds, and temperature of the patient. So if we go through these three symptoms or signs of this patient, so if we first check the pupil size, so if it is a pinpoint pupil, then we check for bowel sounds. So in bowel sounds we check whether it is a hyperactive or hypoactive. So if it is a hyperactive, then the reasons is cholinergic medications or cholinergic drugs. And if it is a hypoactive, the possible cause probably from opioid. Next, again we check pupil size. If it is normal or dilated, then you check for temperature. If temperature is raised, that is hyperthermia, then you check for again bowel sounds. If the bowel sound is hypoactive, then it is anticholinergic, and if it is hyperactive, then it is sympathomimetic. Now if the temperature is low, that is if it is hypothermia, then again we check for bowel sounds. If it is hypoactive, then it is probably sedative hypnotic drugs, and if it is hyperactive, then probably it is some hallucinergic drug. Now the treatment portions. So the treatment start with ABC, airway breathing circulation, ECG monitoring for potential cardiac toxins like sympathomimetic, tricyclic antidepressants, beta blocker, calcium channel blockers. Patients presenting with seizures, they are managed with benzodiazepine, barbiturates or valproates. Those are the agents of choice. And this is coma cocktail that includes dextrose, naloxone, thiamines. So if patients come in comatose conditions with suspicions of some toxin overdose or toxin ingestions, we can start with this. So methods to decrease the absorptions, those are skin and eye decontaminations, GI decontaminations, and methods to increase eliminations, those are multiple dose activated charcoal, urinary alkalizations, extracorporeal eliminations, antidotal therapy, and separately the antidote therapy. And now skin and eye decontaminations, so clothing should be removed. Skins are copiously irrigated with mild soap and water. Hot water should be avoided. Strong detergents, harsh abrasive things to be avoided. Care provider should wear gloves, water resistant gowns, splash resistant goggles, and mask to protect themselves from dermal exposure of toxins. Now the GI decontaminations, process of preventing or reducing absorptions of a substance after it has been ingested. Ipecac induced emesis, gastric lavage, activated charcoals, and whole bowel irrigations are the options. Regardless of the method of gastric decontaminations, a significant amount of toxin remains available for absorption. Now GI decontaminations with ipecac induced emesis, once a time it was a preferred technique, no longer recommended nowadays in emergency department. No overall improvement in clinical outcomes. It may cause persistent vomiting that often occurs that may delay other modes of therapy. Now GI decontaminations with gastric lavage, it involves insertions of a large bore, that is 36 to 40 French orogastric tube, left lateral decubitus positions with the head of the end in the Trendelenburg positions, 250 ml of water or saline instilled with immediate lavage of the same quantity of fluid, and repeated until the recovered solutions is clear of particulate matters or peeled fragments. Now it is considered if potentially life-threatening amount of toxin has ingested and patient presents within 1 hour of ingestions, should not be performed in case of corrosive substance, volatile hydrocarbon, combative or uncooperative patients. It may be associated with aspiration, esophageal perforation, epistaxis, hypothermia, and death. GI decontaminations with activated charcoal, it is more effective than induced emesis or gastric lavage. Preferred method of decontaminations for most poisons. Resuspended in water to achieve a 25% concentration, commonly used as a dose of 1 gram per kg of body weight. An approximate dose is 10:1 ratio of activated charcoal to the toxin amount, and it is contraindicated if airway reflexes are not intact or protected. So first we have to protect the airway. পাওয়া যায় তো কাগজের বাক্সে জারে পাওয়া যায় and GI decontaminations, multiple dose activated charcoals. So it is potential method of enhanced eliminations. Some drugs undergo actually enterohepatic and enteric recirculation. So MDAC interrupts enterohepatic and enteric recirculations, acting as a guard dialysis. And the dosage is 25 gram every 2 to 4 hourly. And cathetic, that is sorbital, usually is not administered with MDAC, as there is risk of serious electrolyte abnormalities. Now the substances that is absorbable by activated charcoals, it can be remembered as ABCD, that is antimalarial quinine, aminophylline, barbiturates, carbamazepine, dapsone. And substances that is not absorbable by activated charcoals, that is fails, that is pesticides, potassium, hydrocarbons, acid, alkali, alcohols, iron, insecticides, lithium, solvents. So we have to use these agents accordingly. And GI decontaminations with whole bowel irrigations. So clean It cleans the gastrointestinal tract by mechanical action without affecting the fluid or electrolyte balance. 1 to 2 liter per hour of polyethylene glycol solution is used for this purpose, and it is continued until the rectal effluent is clear. And in most patients, this usually occurs within 4 to 6 hours. And the heavy metals, lithium, sustained release and enteric coated products and substances that are not absorbed by charcoals, actually this methods is used. Now enhanced eliminations. So first we seen this reduced absorptions. Now enhanced elimination, that is a process of removing a toxin from the body once the absorption has already occurred, and it can happen with multiple dose activated charcoal, urinary alkalizations and extracorporeal elimination. Now we have already talked about these multiple doses activated charcoals. They prevent the enterohepatic and enteroenteric recirculations. So urinary alkalizations, that is the intravenous sodium bicarbonate infusions we use, it promotes urinary eliminations of substances that are weak acids and target urinary pH is more than 7. It is used for salicylate, phenobarbital poisonings mainly, and enhanced eliminations with extracorporeal systems, that includes hemodialysis. So hemodialysis enhances removal of substances with low protein binding, small volume of distribution, high water solubility and low molecular weight. And the toxins that is accessible for hemodialysis, those can be remembered as unstable, that is uremia, no response to conventional therapy, salicylate, theophylline, alcohol, that is isopropyl or methanol, boric acid, barbiturate, lithium, ethylene glycol, and enhanced eliminations in extracorporeals. Another thing is charcoal hemoperfusion, that involves pumping blood through a charcoal canisters, and it can be used for CPBT, that is carbamazepine, paraquat, barbiturates and theophylline. Now the antidotal therapy, this is the specific treatments. Actually first we have to go with the sign and symptom of those patients, then we will follow one Toxidrome, and when then the investigations, the screening test, other test, and when we are sure that this specific toxins has been ingested, then can we use this specific antidotal therapy. That is for acetaminophen, it is N-acetylcysteine. For methanol or ethylene glycol, is it ethanol or fomepizole. Carbon monoxide, it is hyperbaric oxygen. For opioids, it is naloxone. And for anticholinergic, it is physostigmine. For organophosphate, it is atropine and PAM. For methemoglobinemia, it is methylene blue. For cyanide, it is nitrate. No. Methylene blue for methemoglobinemia. For cyanide, it is nitrate. For iron toxicity, it is desphorferoxamines. For digoxin toxicity, for FAF fragments. For beta blocker overdose, that is we use glucagon. Tricyclic antidepressants, the specific antidote is sodium bicarbonate. Calcium channel blockers, we use calcium gluconate, insulin dextrose. And oral hypoglycemics, we should use dextrose, glucagon and octreotide. So that's all actually. Shorts, but we have to memorize all those means reasons of everything which causes meiosis, mydriasis, hypo, hyper, tachy, brady. Then only actually we go to a conclusion. What may be the reasons? Actually there is, but এগুলো মনে রাখাটাই ব্যাপার।
Source of your, I'll just suggest there's a book called Critical Care Toxicology, Dr. Umender Singh.
যেটা ISCCM এর ওটাই বলছি।
That is a very, if you are actually interested in toxicology, most of these tables are sourced from that. তারপরে একটা বই বেরিয়েছে website also incorporates a lot in toxicology, the source and chapters. And just go through it.
ISCCM টা আছে যেটা ওইটাই উপেন্দ্র সিং ওটাই। যেটা
In the medical colleges, people, I think they still use potassium permanganate দিয়ে gastric lavage করা।
শোনা করছে বলতে
Yeah, what is the basis for that? What was the basis?
কপার সালফেট পয়জন দুধে পয়জন
না না সব কিছুতেই একটু potassium মানে একটু pink water দিয়ে করে rather than plain water. I never could understand why.
ওরা মিডিয়াম করেছিল ওরা বলতে কপার সালফেট তখন খেতে লোকে দুধে খেতে সে
Copper sulfate is showing chemical reaction.
ওটা পুরো প্রেসিপিটেট করে দিত
Copper sulfate is horrible. এখন একটা মানে
পাওয়া যায় না।
হ্যাঁ দেখি না it's a matter of what you can access. So rural side থেকে এখনো কেন ফসফরাস মানে বিভিন্ন রকম পেস্টিসাইড তো একটা প্যারাকেট এসছে খুবই খারাপ শুনেছে মেডিকেলতে ট্রান্সপ্লান্ট
তো প্যারাগো
ভুবনেশ্বর থেকে মানে এসছে আর আমরা এখনো অর্গান ফসফরাস অ্যান্টিডিপ্রেসেন্টস মানে যারা
multiple of which
you should always presume that there might be something else. Particularly, কখনো কখনো বলতে চায় না, especially if they come from slightly upper class families, they don't want to talk about it. আর এই medical legal data একটা সমস্যা হয়ে যায়। আমি impulsive overdose বলে একটু problem হলে problem. Salicylates you don't see much. কারণ as because when the 75 পাওয়া যায় মানে you'll have to really take a look আগে বড় ট্যাবলেট পাওয়া যেত পাওয়া যায় না somehow আমাদের এখানে প্যারাসিটামল ততটা দেখা যায় না প্যারাসিটামল দু একটা যা দেখেছি they're all মানে ওই জ্বর হয়েছে ঘোরের মাথায় যে কটা খেয়ে নিয়েছে আসেন 4 ঘন্টা অন্তর খেয়েছে বলে আবার জ্বর আসছে আবার খেয়ে নাও এই করে some people have come but they've not come to harm মানে তাদের জিওডিএসিপিটি 4 মাস 4000 মধ্যে ছিল কিন্তু they were all okay. The paracetamol was one of the commonest poisoning you can expect.
still paracetamol poisoning is
acute liver failure is one of the big causes.
মেডিকাতে একটা দেখেছিলাম মানে অ্যাকিউট প্যারাসিটামল মেডিকায় যখন ছিলাম অ্যাকিউট প্যারাসিটামল পয়জনিং and presented with acute liver failure metabolic acidosis so transplanted জন্য কথা হচ্ছে
Actually, paracetamol পাওয়া যায় that is only one that is available.
Right. Other options.
So that is the when there was a big paracetamol সঙ্গে N-acetylcysteine combined করে ট্যাবলেট বেচা যেটা এখানে একটা প্যারাসেফ করে পাওয়া যায় ওখানে মানে পার্লামেন্টে ওরা খুব করেছিল যে all paracetamol available should be combined.
Antidote দিয়ে খাওয়া
So তখন ওটার কোয়েশ্চেন ছিল যে it increases the cost significantly. কিন্তু যে determined they will find something else so they did not justified বলে ওটার economy. That is interesting. আমাদের এখানে তো পাওয়া যায় প্যারাসেফ টাই শুধু পাওয়া যায়
But paracetamol commonly used drug. যেরকম ডোজে খেলে একদম অ্যাক্টিভেটেড টান দেয়
ওটা তো বলছি ওরকম
ওই নর্মোগ্রামটা না বল
নোমোগ্রামটা তো লেভেলের একটা
নোমোগ্রামটা তো
কতটা খেলে আমি সেম
আমি বলছি ওটা মিলিগ্রাম পার কেজিতে আছে
8 গ্রামের
মানে আমি 10 12
8 গ্রামের উপরে হচ্ছে টক্সিক ডোজ লিভার ফেলিয়ার অ্যাসিডেড হচ্ছে ডোজ অফ 10 to 12 গ্রাম
আদৌ 4 গ্রাম তো দেওয়াই ভালো ফর এক্সাম্পল 1 গ্রাম করে
You see, মানে এটা I never write gram QPS because I mean like ওখানে you look at the average weight of people etc. So so I think I mean it's our 650 গল্পটা তো জানো the tablet used to always come in 500 milligrams but 500 milligram paracetamol tablet was brought under price control. So this the one company the Doro Jara, they came out with 650. Now that is then not on this. So there's a significant price difference between the 500 and 650. Well, significant, it might not be per tablet, but in terms of paracetamol sold countrywide, that's a lot of paracetamol. Oh, in the gram, they were but everything is
এমার্জেন্সি কেসে ইউজ হয় তো অনেক সময় প্যারাসিটামল এর এমার্জেন্সি তখন এই ডোজটা আমরা অনেক সময়
yes,
why did the well built depending on body weight
হ্যাঁ, এটা খেয়াল রাখতে হবে। Plus এখন ওটা
20 milligram per kg দিতে লাগে।
ঠিক আছে।
Dose range is 10 to 20.
IV was 15 per rectal দিলে 20 or 20.
The full analgesic dose is 20
31 milligram per kg. Per dose, per day, per day.
60 গ্রাম 60 কেজিও ধরি তাহলে 1200 টাকা
হ্যাঁ, very well.
ওই জন্য 1 গ্রাম করে আমরা স্ট্যান্ডার্ড হয়ে যায় তো TDS কে 2 days পাই
Natural antibiotic was using too much paracetamol or because
হ্যাঁ মানে আর কি মানে বাকি যে NSAID গুলো একটু রেস্ট্রিক্টেড ইউজ হয়
তাই ভাগ্যিস বললে
opiates আমরা দেখি drug abuse. I mean, I suppose in pockets if you're in Punjab or the northeast you might see a bit more.
বিটা ব্লকার ক্যালসিয়াম চ্যানেল ব্লকার আমি দেখেছিলাম ইএসআই তে থাকতে পেশেন্ট অ্যাকচুয়ালি মরেও গেছিল মানে ঠিকঠাক
মানে কলেজে ব্যাচে স্টুডেন্ট দু একজন দুমদাম ওইসব হতো আর কি বাট নট লাইক ইউ ডোন্ট সি দ্যাট মাচ
আমাদের 710 এর চিন্তা না স্ট্যাটিস্টিক্স 710 সুইসাইড আমাদের ব্যাচমেন্ট ছিল বছর 4 আগে 2019 এ সুইসাইড করেছে ও ফেন্টানিল নিয়ে করে
অ্যাক্সেস টু ড্রাগস
insulin we have seen again there has to be somebody in the family on insulin or you have to be hospital staff
আমাদের একটা ব্যাচমেট বিটা ব্লকার ওভারডোজ করেছিল মানে সুইসাইডাল ইয়েতে 30টা না 35টা খেয়ে নিয়েছিল প্রোপ্রানল সার্ভাইভ কিন্তু তখন গ্লুকাগন ওয়াজ নট রেডিলি অ্যাভেলেবল অ্যাকচুয়ালি কিন্তু তাও আলটিমেটলি
is that you can the paramedics can give it quickly iron that is the only one hypoglycemia de or eta de it's not great shakes so if you're in a hospital let's say IV access and this but otherwise
supporting care very
generally supporting care
নাহলে পেসমেকার টাকা বাট ইএসআই তে একটা ক্যালসিয়াম চ্যানেল ব্লকার ওভারডোজ ছিল আমার ডিউটি ছিল না পরে শুনলাম মানে বাচ্চাটা অ্যাকচুয়ালি মারা গেছিল মানে অ্যারাউন্ড 15 to 16 ইয়ার্স একটা ইয়ে ছিল এবার ওরা অ্যাকচুয়ালি মানে বেসিক্যালি রিফ্র্যাক্টরি ব্র্যাডিকার্ডিয়া ছিল মানে সব রকমভাবে ম্যানেজ করেছিল আর হিস্ট্রিটাও প্রপারলি দেয়নি যেমন স্পেসিফিক মানে ইনসুলিনের যেমন একটা রোল আছে মানে ক্যালসিয়াম চ্যানেল ব্লকারের ইনসুলিন ইনফিউশন গ্লুকাগন আর হচ্ছে ইয়ে ওগুলো ইউজ মনে গেছে সিসিবিতেও আছে বোধ হয় সিসিবিতে 3টে আছে না মানে ইনসুলিন ইনফিউশন ক্যালসিয়াম ইনসুলিন আর গ্লুকাগন না ইয়ে আছে ইন্ট্রালিপিড আছে ইন্ট্রালিপিড আছে সিসিবিতে বিটা ব্লকারে ক্যালসিয়াম চ্যানেলে ইনসুলিন ইন্ট্রালিপিড মানে লিপিড ইমালশন আর একটা যেটা বলছেন ক্যালসিয়াম সাপ্লিমেন্ট
So you have mentioned about activated charcoal. Do you have you gone through recent trials about the efficacy of activated charcoal in acute poisoning? So published data in 2020 I think. Activated charcoal in the first few hours is actually very beneficial.
Within 1 hour preferable মানে যদি
poisons that you have mentioned. If you are applying for AD, to prevent for AD, this toxicology is going
Question
to take up a lot of your time.
But it's slightly different spectrum of stuff.
Exactly.
Interesting.
More about opioid poisoning and paracetamol poisoning, each of which is rather than OP poisoning.
And lithium is actually terrible. And when it can do anything, when electrolytes say renal functioning, cardiac arrhythmias, etc. I mean, that's the only one I have seen. এখানে তোমরা বোধহয় একটা প্যারাকোয়েটের
একটা এমআইসি টুতে ছিল
এই করেছিল মানে plasmapheresis also being done. But I've only seen in lithium people do it because it is very toxic.
Basically, paraquat surviving. I'm going to say paraquat
এখানে হয়েছে এমআইসিউতে দীপক স্যারের
survive was it?
হ্যাঁ
একটা young lady
I have not seen.
একটা মেল
I have forwarded.
অ্যামাউন্টটা হয়তো কম ছিল
অ্যাক্টিভেটেড চার্কোল দেওয়া হয়েছিল
হ্যাঁ, but are we one of the plasmapheresis বা dialysis টাকে it has to be done within 4 to 6 hours, otherwise not.
আচ্ছা ইমোপ্রোডাকশন করা হয়েছিল
Yeah, but you have the trials that show that it only works if it can be done within 4 to 6 hours. মনে করলে it has not been shown to survive. So, mild কিছু একটা হয়তো she was just হ্যাঁ হ্যাঁ I remember it was presented we gave this my একটা present করেছিল ওই খন্ডটা